Folks, we'll go ahead and get started. First of all, let me thank you all for coming. Several of our committee members let me know that they would not be able to be with us this afternoon. There's some other meetings going on, some on transportation, and 2 or 3 other things. And so we may have some drifting in and drifting out. But this really is not so much about the committee as it is really you folks that are out there too. And we're very fortunate that the Admiral's in town today, and I think he's a great source of information. And I know that I heard him speak several months ago, and then he's been busy this morning speaking to some groups and being here. We're just delighted that he's here. And I think Ron's going to introduce him, and what we'll do is just let him come up and begin his remarks, and then hopefully there'll be a little bit of time, maybe if there's some questions or two, that we can do that. And he's here not for any particular issue or anything else, but just really to be a source of information for us and help us to answer some questions and look at some things that maybe he has some insight in that we may not. And certainly Dr. Fitzgerald's here. We're delighted that she's here, and I think all of you that have been attending some of our budget hearings would agree with us that the health department is really moving in the right direction. And Doctor, we thank you for your hard work and your great work that you and your staff are doing over there. And I see we've got our other healthcare expert back here in the back too. Blake's with us. So we've got some good folks here, and we're just going to go ahead and kick it off and begin, and we'll go from there.
Thank you, Mr. Chairman. It's this morning on the House floor we had an opportunity to introduce Rear Admiral Scott Garbison, and he was very, he said, I'd like to go through your resume if I can. He said, don't do that, just kind of, hit the high points, and I did, and it was an honor to have you on the floor of the House and give us an opportunity to honor you, because he is the Assistant Surgeon General, and he is the Director of the Commission Corps of Personnel and Readiness, Chief Professional Officer, and he is a very honorable man. And I'm not going to go through your resume because I think we just want to hear from you, Rear Admiral, and thank you for being here with us today.
All right, well, thank you very much. Let's see if we can get this right angle here. All right, so thanks for having me in Georgia. Certainly my second time here, and thanks to Jim Bracewell. I probably don't even need this microphone, but I'll stand here in front of it. And the hospitality here that you've shown me is wonderful, so I appreciate that. And I met the governor this morning; it was wonderful. And Mr. Chairman and all of you, thanks for coming. I appreciate this. I wrote a report a couple years back. Actually, it was done in 2009. Didn't get released till 2012. Government takes a while, and so I want to take a collegial approach, inform you on what happened on that, the momentum that's been generated for specifically the pharmacy profession, but public health in general. I'll try to refrain from talking about the Affordable Care Act or reform, because that's, I have to clear every word I say then from the Office of the Surgeon General. But I want to bring greetings from the Office of the Surgeon General. I said that at lunchtime. The 18th Surgeon General of the United States, southeastern United States person, Alabama, Dr. Regina Benjamin, sends her best. I texted her today, as well as the Deputy Surgeon General. They both send greetings to Georgia, so welcome to everyone here. We have a situation in healthcare where there's a few burdens on the healthcare system. Everybody's familiar with it. One of them is chronic care. Another one's cost containment. I don't think anybody will argue about any of these points I'm making, but we also have a primary care provider challenge, shortage. So there's things that the nation has needs, and my goal, not as a pharmacist, but as a person that has a purview over all health professions in our Corps. Our Corps is 13 health professions in the public health service. Physicians, dentists, pharmacists, nurses, the whole gamut, the big 6 plus other public health entities, environmental health, engineering, veterinarian, so other healthcare providers in health fields. And my goal was, to find out how you can advance the health of the nation, because that's our mission as a uniformed service, with the capacity that we have, with the resources and the tools that we have. And if you look at physicians in the private sector and physicians in the federal sector, and dentists in the private and dentists in the public, the one thing that jumps out at you the most is the biggest difference of all the professions between private and public is pharmacy. And in the public sector and the federal sector, we utilize pharmacists a lot more than in the private sector to our advantage. If you look at some of the biggest health systems, the VA, the DoD, the Public Health Service, specifically Indian Health Service and Bureau of Prisons, they've managed to incorporate pharmacists into many, many, many facets of primary care by expanding their scope a little bit, but not independently, but by working in collaboration with the rest of the healthcare team. And it's a model that's been going on for 50 years. It's nothing new. So what you hear, and I'm going to sort of, talk separately about my private sector colleagues here, and to say it's not an innovative thing that it just came up in the last 5 years, 6 years, even 10 years. It's 50 years old. And because it's 50 years old, that suggests its success is not just in outcomes or performance, but it's been allowed to last that long. In and of itself is a reflection of the success it's had, because the physicians, in general, control the healthcare system, and they're the backbone of the healthcare system. And if we worked in collaboration with them for 50 years and this has worked, it must be a decent model to use, if possible. Okay. So the goal was to improve patient health and health system outcome. Okay. It was not necessarily to jump pharmacy as the profession to solve the problem, because it's not, but it's a partial solution. It's definitely, absolutely a partial solution, because if you match the need of the nation with the capacity and training of the pharmacist, you find a very good match in many of these realms. So the objectives of the report that we wrote, I submitted it to the Surgeon General of the United States, and she supported it, and I'll tell you about that in a minute. But it was to basically get her support through the fact that it's an evidence-based model, because we have trouble sometimes proving that it's evidence-based. When I do pilot projects, and across time, pharmacy always will show me that in a pilot project. Well, let's do the Asheville project in North Carolina. Let's do this pilot project. And time after time after time after time, it's proven that we have good outcomes. That's not anything new either. So you take those outcomes and you have to build upon it. So the goal of the report was to put that behind us and say the evidence is there, the model's there. Now how are we going to implement this? How are we going to move forward and advance it one more step? The first part was the delivery of that patient care model with the expansion of the pharmacy role in collaboration with the rest of the healthcare team. The second piece of that was recognizing pharmacists as healthcare providers. So when you look at pharmacy in general as a profession, you have a very dichotomous profession. You have the business aspect, and you have all the way through to the clinical aspect, to industry, to research, to regulatory science. You have so many facets of pharmacy, probably the widest range of any other health profession, not just clinical. So we want to keep all those doors open and keep utilizing them where we can in different areas. So all this coming together, recognition as healthcare providers, on the base level, I believe we're healthcare providers. Not everybody has the same practice setting. Not everybody can do primary care work, but we are trained to do so, and we can be involved in that if our roles are expanded. So the thing about primary care is the definition of primary care. If you look at the Institutes of Medicine, if you look at the American Academy of Family Physicians, if you look at any definition of primary care, with the exception of diagnosis, we provide all those services in some practice settings. Not all the practice settings, but in some practice settings. That's very unique, because all providers provide primary care post-diagnosis, and so do we. And that's just sort of left out of the equation because the diagnosis piece comes up all the time. We don't need diagnosis. There's plenty of chronic care conditions out there to deal with, plenty of chronic care burden without the part about diagnosis. So recognition as healthcare providers. The other thing is nobody can truly work in a clinical role without being able to generate revenue. And I don't want to say compensation, because everybody gets afraid when I say compensation. Compensation is like, what am I going to get out of this? We're not worried about what we're going to get out of this. We're trying to generate revenue so that we can continue our value-added service. Okay, so we know how we practice. It's a fact that we work with physicians in many practice settings. It's a fact that there's no turf issues in many practice settings. I know because I've been involved in one for 20 years, so I can tell you that I worked with family practice for 15 years in Indian Health Service. Not as a pharmacist, but as a primary care provider on the medical staff. And I took all their chronic care patients. Okay, so the challenge was, when I say access to care, there's a patient waiting list of 800 people. 800 people do not get seen by a physician because there's no physician to be seen. No PAs, no nurse practitioners. They're all used up. Everybody's done. Their panel's big enough. They can't see any more patients. I come in and take 30 patients from the physician. They're all chronic, dyslipidemic, diabetic, hypertensive patients. I take those patients, I work them up. They bring 30 new people on their panel. Established care. That list goes down to 770 instead of 800. That's the model that we've used in IHS for many, many years and decades. And it's worked because we can handle the chronic care. We're trained to do that. It doesn't infringe upon the scope of the physician. They see more critically ill patients. It doesn't infringe upon the revenue generation of the health system because they can generate revenue for the healthcare system. So it's a win-win situation. And for most people that think that the model is only successful in the federal sector because they don't bill and they don't charge money, that is disproven in Indian Health Service. Indian Health Service is not subsidized like the VA. The VA gets their money up front, and that's that for the whole year. The Indian Health Service has to generate revenue to keep it going. Probably about 52% of its revenue comes from billing Medicaid and Medicare, because we have to, because we wouldn't survive if we didn't. So compensation is an important piece just to sustain the services. It's not anything but like any other healthcare provider. If I provide not too much clinical services, I don't get much payment. If I provide a very high level of clinical service, primary care, I get a little bit more in revenue generation. So it's along the same lines as any other healthcare provider. I don't expect somebody that has not a lot of cognitive decision making or scope of practice to be getting a very high amount of reimbursement. But keep all the doors open, and the fact that we do provide primary care and that we are considered healthcare providers is very important for perception of the patient, for perception of the other healthcare providers in the system. So what makes the report unique? Well, one of the things is that we got past that trying to prove ourselves that we can do clinical outcomes and we can be successful. That evidence is already there. That evidence has been collected for a lot of years. I consolidated it, put it in a report. Okay, it's factual, it's done. Set that aside. You want to look up outcomes? You look up outcomes about any topic in any disease state probably, and you'll show positive outcomes. The second thing is it sort of consolidates the story over the last 50 years of what actually happens. I relay the story of common law versus common practice. How many lawyers in here? Do you have any lawyers? I still don't get any lawyers. I was hoping I'd get some lawyers in here, but common law, it's in practice, it's in precedent, it happens, and it's not necessarily written in a book and regulation, but because of the decision over and over, it sets a precedent, it sets a common law. We have a common practice in pharmacy. It's a fact that we work with physicians on a lot of different patients. It's a fact we provide primary care, and all the facets of primary care except diagnosis in some settings. But yet, we don't seem to have that documented anywhere. We don't seem to have that support in legislation, in regulation, in scope of practice, in even perception by the patient. And that's because most of pharmacy is generally in the community practice setting where they don't get to see the real inner workings of what we can do in that setting and in other settings. So very important that the report showed that story across time. And finally, as far as the support we've gotten, it's really the first report that says these are the expanded roles of pharmacy, this is what we have done factually. And it got support from physicians because we asked a different set of physicians. Okay, so we asked physicians that actually worked in that practice setting. Seems pretty logical, right? Because if I asked Jim if he likes playing cricket in India, if he's never played cricket in India, it's hard for me to take his opinion as all or none. We ask a lot of opinions of a lot of people, and they have to defend themselves in certain situations. They have to feel like it's a turf battle in certain situations. That's fine. However, if you ask the physicians that have worked in this model, there was a 96% approval rate out of the 13 states that we surveyed. That's a huge support factor for us. So I take those opinions very seriously because they do get to see what the capacity is and what the capabilities are. So as you can see, the report's broken down into 4 focus points, and I pretty much mentioned them all. The fact that we already do provide a lot of the primary care, the fact that we can expand our scope, the fact that we can be utilized for many, many more things than just what we're utilized for now. If you look at the big 3, what I call it, chronic care. Okay, chronic care, 76% of all physician visits. 76% of all physician visits are chronic care. I don't need to make a diagnosis as a pharmacist if 76% of all visits across the country are chronic care. The diagnosis is already done. The experts made their call, right? I could help them now with that patient. And I help them manage the patient, not just the meds, but the patient is important because the patient comes to see the pharmacist 12 times a year, where it comes to see the physician maybe once a year, twice a year. And it's not the physician's fault because they've been put in a pretty bad situation. The panel sizes keep growing. What they are expected to do keeps growing. I know. As a family practice provider in New Mexico, I spend, of my 15 minutes I'm allowed with a patient, 8 of those minutes is spent screening for something to cover my butt. Right? I have to screen for alcoholism. I have to screen for depression. I have to screen for sexual abuse. I have to screen for this, screen for that. And by the time I actually get to their main concern, it takes me half of the minutes I have to see the patient. So they're strapped. And if they were given the time or the access that we have as pharmacy, they would do a good job as well. That's just not the way it works. The health system is not built that way. So in collaboration with them, we improve patient outcomes. So that's chronic care. The second big thing is cost containment. If you ask any health system or any hospital, you'd pretty much say that if you're going to contain costs, you have to control medicines, and you have to go to P&T, or you have to go to some group of pharmacists where they can contain costs. And that's just the way it works because meds cost so much. Adherence, or non-compliance certainly is another factor with increasing costs. ER visits. If you can't get access to a primary care provider, you end up in the ER. That's what happens in rural areas, from public health documents where they end up. ER visits, high costs. Right? So even if you're not looking for long-term prevention, like if I said, well, if I kept somebody's systolic blood pressure down, eventually they wouldn't develop, cardiovascular disease. That's a long-term thing. I could prevent ER visits within 1 year, right? If you're measuring anticoagulation, you're keeping the IR in range, and you're keeping people out of the ER, that's huge cost savings right there. Immediate impact, documentable. So the evidence is there, the revenue generation capacity we talked about. I think it's important that the third thing, and I don't know if it's the most important thing, but the accessibility we have as pharmacists. 270 million people visit a pharmacy each week. 270 million people. That's hard to touch that number. That means we're the point of access, and we're incredibly available to the outside world. They may see us in a different light than what we can actually do, and we're not. Our scope isn't maximized quite yet. But having that kind of access, having a ton of training, when all of you that are pharmacists in here know that other than physicians, no other healthcare provider goes to school as long as us. You're the second most healthcare trained professional, okay? You have access to everyone. You contain costs, and you have evidence. And you tell me we're not underutilized. We're definitely underutilized in the healthcare system. And the only reason I know that too is because we have healthcare systems that have utilized us, and it's lasted for a long time, and it's been successful collaboration with physicians. And if you ask any of the physicians I worked with, or any of the physicians my colleagues have worked with, that turf battle just disintegrates because they're being benefited by our expertise as well as theirs. So it's a nice synergistic and mutualistic kind of way to work. Certainly makes it better for everybody, and certainly the patient is the ultimate person that we care about. So in the long run, cost containment, 30 years, 20-some years of evidence-based return on investment has shown that on average it's a 4-to-1 return on investment for including pharmacists in the care and expanding the care, as high as 12-to-1. So for the most part, it's rare that we aren't at least breaking even in our return on investment for expanding the scope. So that is all the things in the report as far as a big snapshot of it. There's a lot of statistics in the report. I named some of the more important ones. And you put the need out there with the capacity we have, and it makes a good logical match that's already proven. And you know what the best thing is? There's really not any evidence out there to refute it. Which doesn't, if you paint that scenario in any other picture and remove, quite frankly, money, politics, things like that, which I know run, that's how the world works. But if you remove that, health and the patient care improves in this model. So whatever we can do to work towards that, even baby steps, even partnerships, or transformative thinking is what I call it, to say, let me expand my mind and think about a little bit more about what a pharmacist can do, or what they're eligible to do, or what their scope allows them to do. Maybe it's not maximized in our state. Maybe it's not utilized to the best of the patient's benefit. And that's all that we talk about in this report. And it's, like I said, it's not a lobbying, it's a factual thing that's it's been a frustration for me because I see the success. It's almost like the public health systems are sometimes a foresight of what could come to be more like our national health system. When we increase eligibility to millions more patients, we don't have the infrastructure to handle that. That's also certainly a projected fact right now. So we're looking forward to that. So key points, summarize it up. We have accessibility. We have a large amount of education and training. We have evidence-based outcomes. There's not much to refute it. We may be in the best position to really be a partial solution to a lot of the healthcare needs. We won't solve the problems. It's going to take 100 things to solve the problems, but let us be 1 through 5 of those solutions. And that's the key point. So I like questions, Q&A. I've been over this with multiple people of all different health professions. Right now I serve on the Multiple Chronic Conditions Committee that's chaired by our Deputy Assistant Secretary for Health at the Department of Health and Human Services under Secretary Sebelius. My input in the last year has been, according to them, more valuable than the previous years of I guess discussion they've had, only because I'm giving them another potential solution which they haven't had in a while. So it's innovative to them. To me, it's long-standing success. But whatever it takes, we're looking ultimately for the benefit of the nation's health and patients' health. So, and part of that is cutting costs and collaborating with other workers. So our infrastructure is in need of this, and I think it's a win-win if we do it the right way. So that's it, sir. Thank you.
Thank you, Emerald. I'm sure there might be some questions, and he has agreed he'd be willing to take a few questions, and we've got a couple of minutes. So does anyone have a question?
All right. I mean, in the federal side, we're covered. Federal court. On the private side, they can buy insurance and expand liability insurance to cover the scope, as long as it's within the scope. But the key thing is, though, is that many pharmacy state scope of practice are broad enough to cover this in collaboration with the physician without changing really any liability. It's just maximizing the scope that's already there to be maximized. It just hasn't been maximized. Collaborative practice agreements are in 43 states right now, out of 50, 44. Meaning it's there, and it can be easily done. And in some states, I'll tell you, it's really progressive.
We have some here in Georgia.
Pharmacy will take care of itself as far as restricting what we can do more than anybody else. We restrict ourselves wonderfully. However, given if you think about other healthcare providers, technically other healthcare providers include clinical social workers, clinical psychologists, dietitians, and then of course the big three like nurse practitioners, PA, and physicians. The level of education there is far surpassing for the most part all the other physicians. For some reason, I don't know if it's because of the perception of the pharmacy behind the counter counting pills, or if it's because of just across time, but given all that education, we've almost been skipped over. Because I know we've talked about clinical psychologists write prescriptions, and PAs certainly have great scope, and they get to do a lot with privileges, but certainly their scope of education is certainly greater than ours. If you think about chronic care and what we're trained on, that's what we get trained on for how many years? And I think that inadvertently the nation sort of skipped over it. I know now there's even a building nurse. Now we have an advanced practice RN coming about because of healthcare reform, and that's great. But really, take a 3-year RN and teach them how to do prescription and medication and disease management versus a 8-year plus residency plus board certification pharmacist that knows how to manage meds and patients, and not allow that privilege in their scope. I don't want to close the door on any other healthcare provider, but I want to open it up to the proper professional needs to help you guys. So, and we're used to working collaboratively. If I didn't have such a body of knowledge or experience behind me, and my predecessors before me for some years, I wouldn't say it's such a capacity. It's out there. It's done. I hope it can be expanded out, scaled out. I hope it takes education. A lot more active. You go right ahead, Miss Public Health, Dr. Public Health.
know everybody. So the idea is were you involved in that?
You know, I wrote what everybody else wrote about ASHA. They put out the results, out to the world, the internet. So, but the collaboration that they're describing is exactly what's been going on in our health system for a long time now. So, or the VA or the IHM. But the difference is in the ASHA project is community private sector partnership, and that's a little bit different. So, somebody else knows what's going on. Part of that too, and I would challenge the pharmacists to do whatever you're looking for. In other words, there's a lot of progressive health out there. State Medicaid payment models, clinical scope of practice models, health system models, and it's out there really. If you're looking for something like this over here, got a lot of that out there. The model in health services that we use is, like I said, the physician come in and establish the care, start them on a course of medication therapy, and knowing that they won't be able to see that person for the next 18 months because they're too busy. That's the pharmacy 2 or 3 times in between that 18 months visit with the pharmacist having to order and interpret labs. And you don't order excessive labs and all that sort of thing. Like any other provider will order what we need to order. Interpret them, which obviously is part of it. Manage the meds until they're ready to go back to work. Most of the time, to be honest with you, the physician will do a phone call and see the patient and say, how the patient's able to get everything's under control. And they just don't. They don't have enough time to see that patient. And it's up to them how frequently after that they want to touch patients. Continuity of care is there because they always come to the pharmacy. Whether or not they go to the patient is Now that's the chronic care world, but there's the public health world, there's the immunization, there's the, I think for the first time ever, pharmacists stick pack medicine and deliver immunization. That's super cool. But that is a reflection of that. Without that,
Well, thank you very much for spending some time with us today, and I certainly think you've given us some food for thought. And I think it's a question that we're all going to be facing. Dr. Fitzgerald, you can appreciate this, is we're going to have more demands on our healthcare system and with limited resources to meet those demands. And so I don't know if it means working harder, maybe working smarter is the right way to do it. And certainly some of the things that have been discussed and mentioned here today can give us some food for thought. But again, thank you for taking the time to come and visit us here and share some good information with us. Anybody else have any comments or questions before we adjourn? Well, if not, thank you all for coming, and Admiral, thank you again for being with us.